Hello, today I'll be talking about Tocilizumab, a retrospective multi-center cohort study of critically ill patients with COVID-19. I'm from the Department of Internal Medicine. We're going to start with some background. This is an schematic representation of the cytokine storm. Here we can see that everything starts with the potential triggers and initiators like CAR T-cell therapy, cancer, and it includes COVID-19. This results in activation of T cells, inadequate negative regulation, and immune hyperactivation. These leads to pathological levels of the cytokines and prolonged activation of signaling pathways that results in systemic inflammation and organ damage and ultimately multi-organ failure and death. IL-6 is part of the cytokine storm, and Tocilizumab is an IL-6 receptor blocker that was proposed for the treatment of COVID-19 to ultimately prevent death. This pandemic started in mid-March last year. In March 13, we had the first positive cases in Michigan, and by April 18, we had over 30,000 cases and 2,000 deaths. This graph shows the daily cases for the whole pandemic year until April 12th. We can see the first, second, third, and fourth wave. If we superimpose the daily deaths, we can appreciate that the death rate was significantly higher in the first wave compared to subsequent waves. Moving to the first initial uncontrolled studies, in a study by Toniati et al. Among 110 adults, they used the Braccia COVID-19 Respiratory Severity Scale as outcome. It was a 9-categorical ordinary severity scale ranging from 0, which is an asymptomatic patient, to 8, which is a critically ill patient requiring mechanical ventilation. And as we can see in this graph, ICU patients had a higher scores compared to WARD patients before Tocilizumab treatment, and after Tocilizumab treatment, we can see that over time, the scores for the scale significantly reduced in ICU patients and in the WARD patients. Similarly, a study by Zhu et al. Among 21 Chinese adults treated with Tocilizumab found that CRP, temperature, and percent of inhaled oxygen decreased over time, whereas oxygen saturation improved over time. One of the initial retrospective cohort studies by Summers et al. Found that Tocilizumab treatment resulted in a higher probability of survival where compared to the untreated. Moreover, the authors incorporated secondary infections in this ordinary scale of 6 outcomes. As we can see, those with Tocilizumab treatment had a higher percentage of discharge, lower percentage of death, and despite having a higher rate of infections among non-intubated patients, sky blue area, and intubated patients in the orange area. These two were higher compared to these two areas. Another retrospective study by Guaraldi found similar results. Tocilizumab resulted in a reduced probability of mechanical ventilation and death, as you can see in this blue line, compared to standard treatment in the red, and there was no difference when Tocilizumab was administered subcutaneous or IV. When looking only at death, we see similar results. Tocilizumab had lower probability of death compared to standard therapy, and there was no difference between subcutaneous or IV routes. So with this in mind, we ask the question, what is the effect of Tocilizumab treatment for critically ill patients with COVID-19 pneumonia in several hospitals in the Southeast Michigan area? Our methods, we conducted a retrospective cohort study of critically ill adults admitted to the ICU between March 15 and May 8th in Ascension hospitals in the Southeast area of Michigan. We diagnosed COVID with a positive PCR test of a nasopharyngeal swab, and we excluded children and adults admitted for respiratory failure not associated with COVID-19. We collected our data by electronic medical record review. Tocilizumab treatment was initially allocated using the age score, but later the decision was made by the infectious disease specialist. Standard dose was 8 mg per kg at a maximum of 400 mg IV once. The primary outcome was mortality. We defined case fatality rate as the number of deaths divided by the number of patients assessed after ICU admission. Our secondary outcomes were ICU length of stay and secondary infections. Data analysis. We conducted univariable analysis using student t-test or Mann-Whitney U for continuous variables and chi-square test for categorical and trend test for ordinal variables. Our multivariable analysis was done using Cox regression models to assess the effect of tocilizumab on mortality. We defined time to event as days from admission to discharge or death. We used step-forward regression technique to build the final model and introduce the potential confounders based on univariable analysis. For our results, we had a total of 154 patients, 34 were treated, and 120 were not. The average age was 62 years, 61% were male, and 74% were African American. 66% patients were obese. Compared to the non-treated, the treated group was significantly younger, had higher rates of obesity prevalence, longer duration of symptoms before hospitalization, fewer comorbidities as reflected by a lower median Charlson comorbidity index, lower creatinine and procalcitonin levels, and higher ALT levels on admission. For the entire population, 92% received hydroxychloroquine and 86% received corticosteroids, but there were no significant differences between treatment groups. However, supportive therapies in the context of critical illness, like renal replacement therapy, prone positioning, and APRV, were received at a higher significance rate than the treatment group compared to the non-treated. Our case fatality rate was 71% for the overall population, and there was a statistically significant difference between the treated with 53% and the non-treated with 77%. The p-value for this difference was 0.007. This graph shows the cumulative survival curves stratified by tocilizumab treatment, and it was adjusted for age, multiple comorbidities, and septic shock. And as you can see here, tocilizumab treatment resulted in a lower likelihood of mortality, for a hazard ratio of 0.47 and a p-value of 0.009. To assess the differences on supportive therapies in the context of ventilatory support, like APRV and proning between treatment groups, we excluded all patients that were not intubated and reran the Cox regression model using the same step-forward regression technique. This second model was adjusted for age, comorbidity, septic shock, and elevated creatinine. We found an attenuation of the association with a hazard ratio of 0.52, but the association remains statistically significant with a p-value of 0.03. Our rate of secondary infections was 41% for the treated and 28% for the non-treated, but this difference was not statistically significant. ICU length of stay was significantly longer in the treated group for an average of 22 days and 7 days in the non-treated. This difference was statistically significant with a p-value of lower than 0.001. Moving on to our discussion, our results are consistent with previous similar studies. Length of stay was significantly longer for treated patients, reflecting higher survival. The rate of secondary infections was higher in the tocilizumab group, and this could also have resulted in a longer length of stay. We also had a significantly higher case fatality rate, and this could also portray a benefit of tocilizumab for the sickest patients. Moving to our strengths, we had a population that was predominantly African American and obese, and this could highlight that tocilizumab could be most beneficial for this specific population that is typically understudied and underrepresented. And as I said previously, our studies are consistent. For limitations, we had observational data, and therefore residual confining is always an issue. We also had heterogeneity in supportive therapies in the context of critical illness, but we assessed this by conducting a new model in only the mechanically ventilated patients. In conclusion, tocilizumab treatment for critically ill patients with COVID-19 resulted in a lower likelihood of mortality. Thank you.